Hello and welcome. My name's Alana Gordon. I'm a reporter at The World covering global health. This is a live Q&A about the coronavirus pandemic, variants, vaccines, and more. So there is a lot to take in right now, and luckily for all of us, joining us is William Hanage, Associate Professor of Epidemiology at Harvard's T.H. Chan School of Public Health. Bill, thanks for joining us.
Hi, Alana. It's good to be with you again.
And you can post your questions for us on Facebook at Forum HSPH, or you can email them to the forum at hsph.harvard.edu. This Q&A is jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and The World from PRX and GBH. As I said, there's a lot to unpack with new vaccine campaigns, a surreal death toll right now, approaching 2.5 million globally. And it seems like every week we're learning about new variants of this coronavirus. Bill, you've stressed that mutations are a natural thing that's expected, but scientists have in recent months ID'd a handful of variants that are of concern, as in a collection of mutations. And so beginning this conversation, I wanted to start and see if you could set up, like, how did we get here? How is this virus evolving? What's happening?
Sure. Well, I mean, the first thing to note is that natural selection obviously indicates that if any mutation or phenotype, any variant of the virus arises, which is better able to transmit among humans, and we expect it to become more common. And in fact, we think that this happened quite early on. There was a mutation, D614G, you may have heard of. You may remember that way back in the spring of last year. And it wasn't entirely clear whether or not that was really more transmissible, but it looks pretty clear that it is now. It's very hard to disentangle these things from the situation that's on the ground in terms of opportunities for transmission and what we call founder effects. But that was a pandemic, meaning D614G, for quite a while. And then in mid-December, it became clear that in the southeast of the United Kingdom, there was the first of the so-called variants was identified with the name B117. And there are now 3 named variants of concern. And they are characterized by not just one mutation, but a number of mutations which have been found or which have been shown in the laboratory to be doing things that we think are important to the virus. And so them all taken together is why we are anxious about them. And as you're probably aware, B117 has been taking over in most of the places where it's been introduced. And it seems to be, it's certainly more transmissible. It seems to be more dangerous as well, somewhat more dangerous. And we know much less about the other 2, B1351 and P1, but I'm sure we're going to get to talk about them later on in this.
And so does this surprise you?
The idea that the virus is going to evolve does not surprise me at all. I think that there is something which is a little bit unexpected about the nature of at least 2 of these. P1 and B117 are both characterized by more mutations than you would expect, bluntly speaking, because the SARS-CoV-2 does not have a high mutation rate. It's not like most RNA viruses. In fact, it has a very, very large genome for an RNA virus. It's got a pretty slow mutation rate. So when we look at these, it's not only that they have a lot of mutations, it's that they have more than we would expect. And it's not clear why that is so, but the opinion that a number of people have, including me, is that it reflects evolution within a different sort of compartment, meaning sort of, rather than just transmitting quickly between people, it's a long persistent infection in one person. So that, because we have studied some such infections, and we see similar amounts of change, and indeed some of the very same changes that we see in the variants. So that's what we think is going on at the moment.
How worried are you about this? Or what is it that worries you about them?
Oh, a number of things worry me about them. And it's quite interesting to think what worries some people more than others. And there are 2 things which I think really people get concerned about. One of them is that they are able to transmit more. And the other is an anxiety that they are able to sidestep immunity, either from previous infection or from the vaccines. Now, coming from an epidemiology perspective, I'm actually more concerned in many ways about the former than the latter, because if something is more transmissible, it has more capacity for exponential growth, which means it is more difficult to control, both in terms of the basic actions that we're able to take to, the non-pharmaceutical interventions, social distancing and all that. And it also means we're going to need to vaccinate a higher proportion of the population in order to control it. Mention on top of that it seems pretty clear by now that B117 is also somewhat more likely to lead to the most severe outcomes given infection. And you've got something which is really quite anxiety inducing. Mm-hmm. Now, the other two, B1, 351 and P1, are anxiety inducing as well, but for quite different reasons. I think we'll probably come to P1 and it's best discussed on its own, but B1 351 has one of these mutations. You may have heard they've been given quite cuddly little names. And this one is called EEK, which is E484K. It means a specific mutation in the spike protein, which has been associated with with a reduction in the ability of neutralizing antibodies to actually target and neutralize the virus. This, I do not think, is going to be sufficient to get very much in the way of vaccine campaigns, but obviously this is a very rapidly developing story.
We have a lot of questions coming in that I want to get to, but when it comes to vaccines, I want to ask about how the vaccines and their effectiveness may stand up against these variants. And also, we're in a moment where there's a very imbalanced landscape of where places have access to vaccines and where they don't. And I wonder what happens if parts of the world are vaccinated and parts aren't, what that means for the virus and variants and that kind of future of the pandemic and its transmission.
Yeah, those are really good questions. So the first thing to say is that the amount of immunity, the amounts of neutralizing antibodies which are generated by the mRNA vaccine platform are very, very large. They're extremely impressive, very immunogenic vaccines. And so even though there appears to be some reduction, it's not likely that it's going to be enough to make a major impact upon the efficacy of the vaccines. So that is good news. It even seems that there is benefit for some of the other vaccines which have had less good press, like Chadox, which is the Oxford AstraZeneca vaccine. That doesn't seem to be as good in some ways, but it does seem to be very good indeed at preventing severe disease. So that in and of itself is a good thing and speaks to the merit of vaccination in general. Now, as you say, it's a really non-level playing field when it comes to vaccines at the moment, both around different parts of this country, but also, and really when you look at the rest of the world, there's very, very large parts of the world which are not going to be vaccinated anytime soon. And of course, those are going to be places where the virus is going to be able to continue to cause disease, cause sickness and death, and continue to evolve. And some of that may be particularly relevant to the third of the variants, which is P1, which I guess this is the point at which I should segue to invite you to ask me a question about P1.
Tell me about P1.
Certainly. So P1 is, it was brilliantly done, so smooth. The P1 is, like B117, characterized by an unusually large number of mutations, concentrated very much within the spike, and including EEK. So P1 is of particular interest because it has been found to be very common, apparently, again, taking over the population in Manaus in the Amazon. And that's of interest because of the fact that Manaus had a very, very bad first surge around May, June last year. It was widely reported as being very, very rapid sort of surges of infection going to hospitals, cemeteries were unable to cope, and so on. However, the upshot of this was that if you looked at blood donors later on, it looked like there was quite a lot of immunity. And it was reported that or it was thought, this was in a scientific paper, that by October of last year, around 75% of the population had experienced infection. Now, even if that's not quite right, that many people with antibodies should be enough to stop subsequent surges being quite as severe. However, it may be hard to imagine, but January was even worse than the first surge. P1, which was a variant which was common there, started to become noticeable in December. And as I said, January's hospitalizations and deaths were even worse than the first surge. And that was associated with the variant known as P1. And the reason why this is concerning is not necessarily that we think P1 is going to be able to sidestep vaccination. I mean, we don't really have good data on that, but given how effective the mRNA vaccines seem to be, I'm reasonably confident that that's going to be the case. It's more the fact that if it could happen to Manaus, we have to ask ourselves whether it could happen anywhere else. And even though, some parts of the world close to us may be getting vaccines pretty soon, a lot of the world isn't. And so that, I think, is something that, at a global level, we really want to be thinking about very, very carefully.
So you've basically outlined three main variants of concern that you're keeping an eye on, and kind of the cautions of how this has happened, or what is happening, what that can tell us about how to be mindful of future responses and what's happening right now. This question comes from Maria. Now, what you're saying is that, right now these vaccines seem to be quite good, even with the variants. But this question is about, let's say, we are also hearing about companies doing tests, booster shots, updates based on these things. Can variants be plugged into existing vaccines, or if things develop and change? Is it like how the flu vaccine is adjusted each year? Or do researchers have to go back to the drawing board to develop vaccines against new variants? I know that's a little bit future question, but also relevant.
Oh, it's extremely relevant. The great thing about the mRNA platform is that it's comparatively easy.
That's
to
the Pfizer and the
plug in.
BioNTech.
Yes, that's correct. The sort of the time span that is sort of talked about when people throw time spans around in conversation is they say that you'd be able to put something together in 6 weeks. So it's really quite there's potential for a rapid response. And I think Moderna is already developing one based on the spike in B1351. There was also, I believe, I don't want to speak too out of turn because it sort of flashed by yesterday amid the huge quantity of information that I'm presented with every day, but it looks like the FDA have been seriously engaging with the idea of helping previously established vaccine platforms be able to go through, rapid regulatory processes. So it's, people are on the front foot here. It may be more difficult to tweak the other vaccine platforms, partially because of the fact that they rely on a more innocuous virus in order to carry the material from SARS-CoV-2 and present it to the immune system. And if the immune system has already got some reaction against that virus, then subsequent things based on that platform might not be as effective. So it's something which people are thinking about.
I didn't quite hear that.
That's right. They might not be as effective because there's already immunity against the other part of the virus. But that's not a given. It's something which we need to investigate. So, I think there's reasons to be optimistic. And long term, I think that we can be pretty confident. But I'm having a certain amount of anxiety that over the short term, we might be letting our guard down a little bit too soon.
This question comes from Doug about vaccine resistance, semi-related. It would seem unlikely that a virus like this one would have the ability to develop resistance to a vaccine or a vaccine that it's never been exposed to, yet that's what some people fear. And so can you comment on that?
Yeah, a lot of people suggest that vaccine resistance is a big deal, but that's actually, I would rather nobody use the words vaccine resistance. Vaccines are not antibiotics. Antibiotics and vaccines are really very different sort of therapeutics. Antibiotics are given to people, not always, but they are often given to people to treat an infection, whereas vaccines are given before people, ideally, have ever been anywhere near the infection. And one of the impacts that has is that when the infection sort of takes off in the person, the immune system jumps in very quickly, which means that there's less opportunity for the virus to mutate within that particular person. So, and if you imagine an unvaccinated population, well, there isn't any pressure on the virus in that population to evolve immune escape, or evolve vaccine escape, sorry. There will be pressure to avoid the escape from immunity following infection. And that will to some extent overlap with vaccine efficacy. But as I was saying earlier, the vaccines produce very, very large amounts of antibodies. And so the ability of the vaccine to protect goes from being really, really very high to maybe not quite as high. But that's still a very good thing when it comes to protecting people and managing to control the pandemic. So I'm pretty relaxed about this. You'll hear some virologists who are anxious about it, but the people who are more, who've like studied responses of pathogen populations to vaccines from an evolutionary perspective are more relaxed.
This question is about vaccines and related to transmission. And it's from Carla. Are we able to say yet whether the vaccines have an effect on transmission of the virus? And does it, if so, does it seem like each of the vaccines affects that transmission equally? Are there differences? And how then should that inform how vaccines are distributed?
It's a very important question for a lot of reasons, because the ability to, I mean, a vaccine that prevents disease and not transmission is still very useful. You know, let's make that clear. However, a vaccine which is able to prevent transmission has this kind of value-added effect, because it means that anybody who is vaccinated becomes part of this big fire break, which manages to dampen down the virus in the population and can contribute towards reaching a level of population immunity in which the virus will not be able to maintain itself. Now, there's various amounts of data from this, and there's more coming out every day. The quality of I'm going to try and summarize what I think is my current impression of the body of the data altogether. There is some evidence that the mRNA vaccines do prevent transmission. Some of it a little bit, there's some which is a little bit direct, which is from when you sort of look at people who have been swabbed when they go to get their second shot, for instance. And there's also the quantity of neutralized antibodies that are produced seem to be consistent. It seems implausible that there would not be any effect upon transmission. How large the effect is not entirely clear, but I think it's reasonable to think it's pretty high. The issue with AstraZeneca, I don't know anything about Johnson & Johnson, I should say, not at present. The issue with the AstraZeneca vaccine is it may be somewhat less, but that's also probably the most difficult vaccine to be definitive about as a result of the way the trials were done. The trials had a lot of what we call subgroups. And what that means is that, it's quite difficult to consider all of them together, because the subgroups themselves are quite small. And that means that even while I think that it's probably a pretty good vaccine, certainly in terms of preventing disease, it's a little more unclear as to what it's going to be doing in terms of transmission. And of course, it's a vaccine which is also the one which has attracted most concern in comparison with B1351. And South Africa is now no longer planning on using it. But having said that, there was data that came out of the United Kingdom yesterday, which suggested that people vaccinated with it were equally unlikely to suffer severe disease as people who'd had mRNA vaccines.
This leads to a related question from Graham, which is that given the data from Israel, England, and Scotland, and the reworking of the original US Pfizer data that's been published, should the US be adopting a one vaccination approach followed by a 12-week gap, which is not the case right now? And how does now the data that we're learning about in some of these places affect how you might see the approach to the speed of vaccination and to doing vaccine rollouts in light of where we're at with this virus and the pandemic.
Well, I want to start by pointing out that you are obviously very on top of these data. I'm impressed. So the issue is that the issue arises from the fact that the mRNA vaccine trials had a particular period between the first dose and the second dose. Now, that was relatively short. It's important to understand that one of the reasons that drove that was that just in order to be able to get the trial done in time, because if we'd been leaving the doses like 3 months apart, we might have been waiting considerably longer before we'd actually have data on whether or not the vaccines worked. So what has happened in the United Kingdom has been an urge to stretch that time out so that people get the vaccine, they get their first dose, and then they have the second dose up to 3 months later. And the idea is that you get as many first doses into as many people as possible, because the first dose does provide protection, some protection. Not quite the same level, but some. And the goal there is to achieve population level protection and avoid the devastating consequences. And, you know, we should remember the United Kingdom has been in a truly dreadful place over the last few months. Cases are coming down now, but they've had an extraordinary surge, partially as a result of B117. So this plan, which you put out there, I think it's best to understand it in terms of a short-term impact versus a long-term impact. Because the short-term impact here, which is good, is getting as much immunity as possible in order to see off and just trying to deal with an absolutely urgent public health emergency. The second dose, on the other hand, is going to be the one that provides the real long-lasting immunity, which is going to be helpful in the future, because it's unlikely that we're going to be, you know, this virus is going to be with us for some time at least. And so we're going to want to be having good long-lasting immunity in a substantial fraction of the population.
This leads to a question from Matt, which is, can you speak about the difficult and nuanced message about what happens after people get 1, or in this case, 2 doses? There's a lot of discussion about how much things can and should change, like with mask wearing, especially if you're around people who've not been vaccinated or fully vaccinated. I know this might be a little bit beyond your scope, but could you talk about that?
Sure, I can certainly talk about it. I mean, I went for a walk with a good friend and a few others a couple of weekends ago. It was cold, but you know, that's New England. He's a frontline physician. He's received 2 doses of one of the mRNA vaccines. I don't know which one, and he was still wearing a mask throughout. Now, there are many good reasons why you should do that. And one of the most important, I think, is that until we have reason to think that a sufficiently large proportion of the population have been immunized, people don't look at you and think, oh, he's been immunized, she's been immunized. They don't know that. So wearing a mask is a good show of solidarity with your fellow human beings who have not been lucky enough to be immunized yet. And there's also a very low risk that you would transmit if you had been vaccinated. And I mean, there are some cases of infection following vaccination, not very many, but there are some. And so while there's a low risk that you might transmit to people, under the current circumstances, I just think that it's a sensible thing to do to extend it somewhat. But we want to be clear that we are, if we can vaccinate enough people, on the road to a better place. This is not something which is going to be indefinite. You know, nobody is saying this is going to be happening forever, but we do think it may well be that we are still needing to take at least some interventions for quite some time yet.
That is a hopeful look. One thing we haven't gotten to yet as we wrap up has to do with, we're seeing in a lot of countries like the United States a drop in cases. And in what way do we think about vaccines playing a role? Just lots of infections. So more people are infected and perhaps aren't getting reinfected. Obviously, this Brazil story, Amazon example, is a cautionary tale. How are you looking at what we're seeing right now with this drop in cases and what we know about the virus? What's happening?
So the cases are dropping quickly, and that's good. Long may it continue. But that means that while there may be a light at the end of the tunnel, we're not there yet, and this is why. The first thing is that we know quite a bit about coronaviruses from the study of the other more innocuous ones that just cause colds. And you know when they peak? Every year, you get the most of those coronavirus cases around the start of January. So if you simply look at that, then you would be expecting other coronaviruses to start to be reducing around that time as well. Now, it's not the case, I think, that all of what we are seeing can be explained by any type of immunity. For a start, we haven't really got a very large number of people vaccinated yet. I mean, it varies, but for instance, in Massachusetts, I think based on modeling that I've been involved with, I think we'd think at the moment that a bit over 30% of the population might have either been infected or have vaccine-induced immunity. So that's good, but it's still not it's still not enough to explain the drop. What I do think, the other thing to say there is that you can see the drop happening in states that have had such vastly different pandemic stories as California and New York. I mean, it's remarkable how many states have a small peak, have either a large peak or a small peak sometime around the 10th to 15th of January. Even Hawaii has a little peak there. So I think that speaks to the contacts that people made over the holiday period and the little transmission events, those transmission chains that were started then. And after that, we're getting into the period where we expect coronaviruses to be declining. Now, seasonality contains a component both from human interaction patterns. It's one of the reasons why school years are often connected to seasonality and why the holidays are connected to seasonality. But there's also something to do with the climate. And while the weather isn't that much better, I mean, if I look out the window behind you, I can see snow on the ground and all of those other things. We do expect it to be helping drive cases down somewhat. As we know from the summer of last year that the virus is not going to go away over the summer, but it should be, we can expect it to be somewhat lower. And I think that we need to be bearing that in mind and not thinking, that's fine, we're done, the pandemic's over. Because we're going to have to be looking quite carefully, I think, at what's going to be happening in the fall. So I'm kind of optimistic in the short term, but a bit more anxious about the longer term.
We're about at the point of wrapping up, but I wanted to ask, what are some of the main questions you still have when you're thinking about these variants that are emerging, converging with vaccine campaigns, and where we're at in the pandemic? We're at this point where we're starting to see some clues about the vaccines and how they're rolling out and what that means. And now with these new variants, what are the key questions in the coming weeks and months that will give you more certainty about how this is headed, but also that you're still trying to figure out?
Well, the largest number of questions I have are all around P1. We don't understand, I think, at all well enough what made Manaus happen. My reaction to Manaus is rather similar to my reaction around this time last year when I looked at Wuhan and think, well, whatever happened, Wuhan happened. And so I want to understand I want to understand a little bit more about the nature of the virus. I want to understand something about the basic epidemiology, the ages of people infected and so on. So that's one of my biggest questions. I have similar questions about 351. And I mean, finally, we haven't yet mentioned one of the questions about B117, which is that despite having some mutations in common with the other variants, B117, when it was first described, did not have EEK, E484K. However, since that time, there have been multiple independent mutations in the B117 lineage that have led to EEK being acquired. And indeed, that's already been introduced in the United States. So I think we want to understand is how these variants are going to continue to evolve and potentially be able to cause a sting in the tail. And in particular, thinking about people, including younger people who may have already been infected and have some immunity, but not be sufficient to be able to resist infection with some of these variants.
Do you think it's a matter of time, or to what degree do scientists have the tools to be tracking this and the infrastructure? I know, for example, in the UK, there's a lot of sequencing through a kind of national system. Of course, there's a global sharing database, several like GISAID, but I know in the United States, scientists have been really raising the alarm that there's not enough tracking. And I know that there was some funding released for that recently. How much of this do you feel in the dark about even knowing what's going on?
Well, I want to start out by pointing out that the UK has done amazing things. I mean, I sometimes joke that I actually affect this accent just in order to pretend that I'm from there, so that, just to try and ride on the coattails of the amazing success. It's more difficult in the United States for a lot of reasons. One of them being that it can be quite difficult because of the fragmented nature of the system, it's not always straightforward to take a sample which you test for the presence of the virus, and then you also determine the genome sequence, because testing companies don't necessarily have any interest in determining genome sequence. That's for, academics like me. But there have been some really impressive efforts, which have been, led by some people at CDC trying to work together in order to get some of these companies to supply the RNA from their testing. And that has been quite helpful. That's enabled us to determine, for instance, or at least get a handle on the introduction of B117 to parts of California and Florida. The difficult thing is that because these companies are not national, it depends on whether or not you have a company, one of the companies who's doing this, actually doing a lot of testing in a particular part of the country. So there are large parts of the country where we don't really know very much. There's also large parts of the country where we're now ramping up testing. And if you are like me, you'll see preprints and sometimes even pre-preprints, people talking about their locally important lineages of the virus and arguing that they should be classified as a variant of concern. So I would like to actually say to everybody, just cool your jets a moment. The important thing is to get enough sequence data that we actually have a decent idea of what's going on the ground. And we're getting better. We are definitely getting better, but there's still a ways to go yet.
This question, there's just a few more questions here. I hope it's okay to run over a little bit. This question's from
Yep.
Bo.
Sorry, I have two screens. I have two, so I'm always like, I can see things coming in on here, and
wow.
that sort of distracts me.
So this is from Bo, and the question is about hybrids. I read recently that two variants, one originally discovered in California, another in the UK, have combined. What makes hybrids different from other variants, and are there reasons to be more concerned about them?
So yeah, these viruses are produced by a process called recombination, which is something I've spent many years of my career studying. So recombination is when you end up with a mixture of two lineages, when genetic material comes together from two individuals. Now with us, that happens every time that we have children. But with pathogens, it can happen. And it's been known to happen with coronaviruses. It happens when two different lineages infect the same cell. And then what comes out can be a mixture of both of them. And it's an important way of generating variation. But when it comes down to it, it's a way of generating variation in the same way that mutation is. Where it does matter is that you can sometimes get multiple changes in one go, because rather than there being a point mutation, you're actually getting a lot of the mutations that characterize the other lineage. And also, they're road-tested mutations. They're good enough at least to have managed to infect the same cell as you. So it can be a useful way of exploring this kind of space, or the space of possible mutations. On the other hand, coronaviruses are known to recombine, and there isn't necessarily a reason to think that that type of mutation is particularly more worrying than any others. And I think the report that you're referring to, so far as I know, is only at this moment a PowerPoint slide and has not been thoroughly published anywhere. So I'd pause a little bit before getting terribly concerned about it. I'll note again, B117 got EEK by mutation. I mean, that the virus is perfectly capable of managing to evolve in that way. As time goes on and we get more diverse virus populations, we should expect that recombination might happen. But whether or not it's going to make a major contribution to the future course of the pandemic remains to be seen.
This question's from Gary. This will be the last one. Along these lines, you've talked about how some of these variants in particular have been shown to be more transmissible. How do you measure that? Like, what does that increase in transmissibility even mean scientifically?
Mm-hmm. There are a number of different ways you can measure it. I mean, some of them are the most direct thing, which is that you look at the attack rate, as in the proportion of close contacts who become infected with one particular variant as opposed to another. You can also look at it in terms of asking what proportion of infections in a given place are the variant. So for instance, this was one of the things that was particularly key to the identification of B117 back in December. It was originally detected in Kent, which is in the southeast of England, as an anomalously large cluster of unlinked but genetically almost identical viruses. And then over time, they realized that in that part of the country, the proportion of things that they were sequencing was increasingly B117. So that indicated that it was outcompeting the other viral lineages that were present. And then you can look at the rate with which it's doing that, and you can use that to estimate things like the doubling time. And from that, you can relate how much more transmissible it has to be in order to have that doubling, to have those characteristics, those epidemiological features, the doubling time and so on. And there is still a little bit of uncertainty about whether or not it's due to the extent to which some of these things are due to being more transmissible versus maybe just more able to transmit quickly. It looks like B117 by now is certainly more transmissible. In fact, it may take a little bit longer to transmit. So, but taking all these things together enable you to do that. I mean, just as an example, as a counterexample of this, modeling with B1351 from South Africa suggests that you can explain its increase in one of two ways. You could say that it's either more transmissible, or you could say that it's better able to reinfect people who were previously infected. And both of them manage to explain it. So at the moment, you can't really tell the difference between those. If hopefully that will become clear over the next few weeks or months.
And I'm remembering now the way we wrapped up this conversation in this space previously is the one thing I want to ask when you talk about something being more transmissible in these variants. Do you know more? Does that affect how you prevent and stop transmission in terms of what, as a person navigating this world, does it mean that it's with masking or distancing, that it's just more transmissible through those things? How do you translate this to our behaviors and prevention?
That's a great question. I mean, again, one of the things that whenever I'm talking to you, Alana, I always want to try and provide a certain amount of help people have some confidence that they can handle this, because really the ways in which you handle this are not that dissimilar from how you'd handle the virus before. I mean, wearing a mask is going to help. Avoiding gatherings indoors is going to help. I mean, all of these things. The upshot of it is that it's not some kind of magic virus which is coming out of, which is a reason for fatalism. But it is the case that if you were doing things already that place you at risk of infection, then you're more likely to be infected with this. So don't do the things that put you at risk of infection.
Well, with that, I think it's time to wrap up, and that concludes our discussion. Thank you for fielding my questions and everyone's questions that have been coming through, for your time.
Thank you.
And this Q&A has been jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and the World from PRX and GBH. You can view this full discussion on our Facebook pages and send feedback at Forum, HSPH, and PRI, the World.